Stretching is the elongation of pathologically shortened or tightened soft tissues using therapeutic techniques. It is essential for restoring flexibility and function. There are several types of stretching: passive stretching, proprioceptive neuromuscular facilitation, PNF, and self-stretching. Each type has unique methods and applications. Passive stretching can be performed manually or mechanically. Manual stretching is done by a therapist and includes static and ballistic stretching. Mechanical stretching uses devices for prolonged or cyclic stretching. Static stretching involves slow, prolonged stretches to avoid reflex contractions, increasing flexibility safely. Ballistic stretching uses bouncing movements, which can increase flexibility quickly but may risk injury due to poor control. For athletes, the Progressive Velocity Flexibility Program gradually increases the speed and range of stretching, starting with static stretches and progressing to fast, full-range movements. Mechanical stretching uses devices like serial casts, pulleys, dynamic splints, and traction tables to apply low-intensity, long-duration, or cyclic stretches, often achieving greater flexibility than manual methods. PNF, proprioceptive neuromuscular facilitation, uses neuromuscular activities to stretch muscles. Main techniques include hold and relax, contract and relax, and slow reversal, each involving specific muscle contractions and relaxations. Self-stretching is performed by the patient, often following a therapist's guidance. It helps improve neuromuscular facilitation and muscle relaxation using similar procedures as passive stretching. The stretch reflex is controlled by afferent and afferent nerve impulses. Muscle spindles and Golgi tendon organs detect changes in muscle length and tension, triggering reflexes that protect muscles during stretching. Muscle spindles contain intrafusal and extrafusal fibers, detecting stretch and sending signals via nerve fibers. Golgi tendon organs, located at muscle tendon junctions, sense tension and help regulate muscle relaxation. The stress-strain curve explains how soft tissues respond to stretching. The elastic phase allows tissues to return to normal, the plastic phase leads to permanent elongation, and the failure point results in tissue tearing. Stretching is indicated for post-traumatic or post-immobilization stiffness, restrictive mobility, contractures, and more. Contraindications include synovial effusion, recent fractures, sharp pain, infection, and certain joint conditions. Physical modalities like heat, massage, oscillation, joint mobilization, and active exercise can enhance the effectiveness of stretching by increasing tissue relaxation, circulation, and flexibility. Stretching can target muscles, joints, or skin. Muscular stretching involves performing the opposite action of the muscle. Joint stretching focuses on soft tissues around the joint, and skin stretching is used for contractures. Various passive and self-stretching techniques are used for lower limb muscles such as the tendoachilles, dorsiflexors, quadriceps, hamstrings, iliopsoas, gluteus maximus, hip adductors, and iliotibial tract. Each has specific patient and therapist positions and procedures. Upper limb muscle stretching includes techniques for the pectoralis major, biceps, triceps, and forearm flexors. Both passive and self-stretching methods are described with specific positions and procedures. Joint stretching targets the soft tissues around joints, including ligaments, capsules, and cartilage. Techniques are described for the shoulder, elbow, forearm, wrist, hip, knee, ankle, and subtalar joints, each addressing specific movement restrictions. Skin stretching is used for contractures caused by burns, immobilization, or trauma. The technique involves stretching the skin in the direction of restricted movement, similar to joint stretching,